My name is Aaron Kesselheim. I'm a professor of medicine at the Brigham, and and with Leah Rand, who I'll introduce in a second, we have the pleasure of organizing this Health Policy and Bioethics Consortium on behalf of the Program on Regulation, Therapeutics, and Law at the Brigham, the Harvard Medical School Center for Bioethics, and the Pham Center at the school, Harvard Law School. And we have a great session today. We're going to talk about the Indian Health Service and the extent to which we're meeting our ethical and our obligations. Please, if you're online and you have a question for the group, please use the Q&A feature. We're going to be monitoring those, and we're going to have some time for interaction and Q&A at the end. If you are discussing this on any social media platform, you can use that the hashtag HMS Bioethics. And if you have any technical issues online, please use the chat feature. If you're interested in this series, please check out the Bioethics HMS.harvard.edu website for subsequent information. The goals of the consortium are very straightforward. The idea here is to try to articulate key issues in healthcare and public health that involve ethically challenging policies and practices, bring together experts with different perspectives to consider and propose solutions, and to try to stimulate conversation and further academic study of the topic. This is the 8th year that we've been doing this, and it just keeps getting better each year. In addition to today, we have the rest of the session, the rest of the fall semester set up, including examining the Veterans Health Administration in November, and then ethical issues related to telehealth. Let me introduce my co-organizer, Leah Rand, who will describe today's session.
Thank you, Aaron. So we're really pleased to welcome 3 experts today to discuss the Indian Health Service with us. And I'd like to introduce our moderator for today's session, Dr. Tony Pham, who is a psychiatrist at the Depression Clinical and Research Program at Mass General Hospital, and a researcher at the Center for Health Disparities and an interdisciplinary psychiatrist at the Primary Care Psychiatry Clinic. Tony completed his undergraduate training at the University of Virginia and volunteered extensively with Hurricane Katrina survivors, and he went on to pursue an MD at Tulane University. During medical school, he continued to volunteer in New Orleans before transitioning to facilitate a survivor program following the 2011 Japan earthquake, tsunami, and nuclear disaster. After medical school, Tony completed a psychiatry residency and a master's in global health at Duke University. As a psychiatry resident, Tony completed a project that examined the role of spirituality among chronic kidney disease patients of rural Robeson County, North Carolina. And as a global health pathway and Fogarty International Fellow, he investigated the intersection between Nepali traditional healers and conventional psychotherapy. More recently, he completed a Harvard postdoctoral fellowship that examined the role of culture as treatment among American Indian communities. Tony has published extensively on behavioral health services and best practices for community-driven psychiatry and suicide prevention. Tony, thank you for joining us.
So I want to introduce the topic. As many of you know, the Indian Health Service is the federal agency responsible for delivering healthcare services to American Indians and Alaskan Natives. Despite treaty obligations, the Indian Health Services has been chronically underfunded, even in comparison to other federal health programs, and health disparities continue to persist. This session will consider the complex laws governing tribal and federal health programs, which were highlighted during COVID-19 public health actions, effort to improve the tribal health care, and what can be done in the future for the federal government to meet the obligations. So I'd like to introduce our presenters. The first presenter over here is Aila Hoss. Professor Hoss is an attorney, professor, and writer with expertise in health law and federal Indian law. Professor Hoss completed her BA at Emory University and her JD at the University of Oregon School of Law. She practiced public health law as a staff attorney for the CDC and Prevention's public health law program, and served as an assistant professor and faculty advisor at the University of Tulsa College of Law's Native American Law Center. Currently, Professor Hoss is an associate professor at Indiana University McKinney School of Law, where she teaches and researches at the intersection of health law and federal Indian law, particularly tribal public health law, and the impact of federal Indian law on health outcomes. Her work has included supporting the CDC's Ebola Emergency Operations Center, developing a variety of resources on tribal emergency and preparedness law to support tribes and their partners when navigating emerging issues such as the Ebola and natural disasters. Serving as faculty member for the CDC's Working Effectively with Tribal Governments course. Her work has also included supporting tribal advisory committee meetings and tribal consultation sessions, providing legal technical assistance to state, tribal, local, and territorial governments as they sought to improve public health within their communities, serving as faculty member of a course alongside tribal members that focus on working effectively with tribal governments, and collecting and analyzing state laws that support or require consultation or engagement with tribes to facilitate intergovernmental partnerships. She is an active member of the Indiana Bar and a proud Iranian American. Dr. Sequist is an internationally renowned physician leader who has dedicated his career to addressing equity and racial disparities in healthcare. He's a practicing general internist at Brigham and Women's and is a professor of medicine and professor of healthcare policy at Harvard Medical School. He is an elected member of the National Academy of Medicine and has been named a top 25 minority leader in healthcare for modern healthcare. Dr. Sequist is a member of the Taal Pueblo tribe in New Mexico and has seen friends and family members in tribal communities who have faced dramatic inequities in healthcare. Dr. Sequist graduated from Cornell University. He received his medical degree from Harvard Medical School and his master's of public health from the Harvard School of Public Health. Completed his residency in internal medicine at Brigham and Women's. Dr. Sequist's federally funded research is focused on quality measurement and improvement, healthcare equity, patient and provider education, and the innovative use of health information technology. When he served as Chief Patient Experience and Equity Officer at Mass General Brigham, he was a key architect in the development and deployment of the Systems United Against Racism priority and led the system in making tremendous strides to remove race in clinical protocols, increase screening and resources to reduce health gaps, and improve access to care for patients. He also ran the Harvard Vanguard Medical Physicians Volunteer Program at the Navajo Reservation in New Mexico to provide much needed medical care for American Indians. Since then, he was named the Chief Medical Officer at MGB and has been leading system-wide strategies for improving patient experience, quality, safety, equity, and community health, among other duties, including serving as the director of the 4 Directions Summer Research Program at Brigham and Women's and the medical director of Brigham and Women's Physician Outreach Program with the Indian Health Service.
All right. Okay, give me 1 second here then. So, and thank you everyone for this invitation here. I have just a couple of slides and then I'm going to go more to kind of discussion. So it's really kind of a pleasure to be here. I am, so my name is Tom Sequist. I'm a primary care doctor at the Brigham. I'm a member of the Taos Pueblo tribe, which you see here. This is our traditional village in the mountains of northern New Mexico. What I wanted to do for the first maybe 10 minutes here is I just want to level set with everyone on the health outcomes that we're talking about for the Native population. So these are relatively, recent data that track life expectancy at birth, probably, one of the most important health status measures that we have from 2019, 2020, and 2021. It's actually one of the first sets of years that we've had nationally representative data that include the American Indian and Alaskan Native population from the CDC, the National Vital Statistics System. And a couple of things that I just want to point out here with these data. First is you can see that regardless of race or ethnicity, the life expectancy was going down over this time period. That is the impact of the COVID pandemic. The second is you can see that the life expectancy among the American Indian Alaska Native population is among the shortest life expectancy, if not the shortest life expectancy in the country. So what is really driving this premature death? And that's what's over on the right. These are not, just to be clear, the leading causes of death among American Indians. They are what causes premature death, this life expectancy gap. And you can see one of the biggest issues we have are unintentional injuries. I really point that out because as we think about solutions to improving the health status, and we'll talk about the Indian Health Service and other aspects of healthcare delivery, it's really important to understand that probably the biggest thing and the first and foremost thing to address are public health things, which we'll talk about, as well as public policy interventions as well. I'm going to say one other thing about this outcomes data and life expectancy data. These are actually the same data. They're just actually put in a different format because they are meant to kind of highlight something really specific. You can see the American Indian population life expectancy in 2021 starting at 71.8 years. And by the end of 2019, and by the end of 2021 was down to 65.2 years. You can see how big that difference is compared to the other race and ethnicity groups in the country. And to put that in another perspective, another way to look at this is that the life expectancy at birth of 65.2 years is the life expectancy of the total US population in 1944. So we are talking about, 60 to 70 years worth of a gap in advances in life expectancy that exists for American Indians. So this is a monumental challenge. It's a crisis when we think about this population. And what is that really coming from? You can see here the difference in what causes death and the mortality rates between the American Indian population and the white population. Of course, in 2021, we're talking about COVID-19. But even aside from that, you can see the difference in death rates for other conditions like liver disease and even sadly suicide and other mental health disorders. So there are large differences in very specific areas and outcomes between Native Americans, American Indians, and the white population. To put a little bit of a finer point on that impact of COVID, what you see here are the rates of death during the peak of the COVID pandemic in 2020 from April to November of that year. And you can see the difference in mortality rates between the Black and Indigenous populations and the white population. These are national data, but it becomes even more stark when you go down to the individual state level data. This is Arizona looking at the same time period, and you can see mortality rates for the Indigenous population that are 3 to 5-fold higher than the rest of the population in Arizona. And so that when you look at that loss of life in the Native American population from 2019 to 2021, this is the kind of experience that was driving that. But you can measure this obviously outside of the COVID pandemic era and outside of a specific focus on that particular condition, which was obviously terrible in nature and continues to cause public health concerns. These are data just surveying American Indian and white patients and showing the differences in health status and self-reported health status and the number of mentally unhealthy days experienced, the number of physically unhealthy days. And you can see across the board, the Native population really, regardless of the way we measure health, whether it's actual survival or in this self-reported mental and physical well-being. We can look in the mental health space. I think it's really important that we understand that there is a crisis going on in the Native population for drug overdose and for suicides. This chart sort of exemplifies that problem that's going on right now in the American Indian Alaska Native problem. So how do we start to think about addressing this in the delivery system context? I think we have to start with thinking about social risk factors. Things like income, housing, employment, education. Then we have to think about measurement. We have to really be able to measure the care, look at the data like I was just showing here earlier, but much more data than that to be able to drive improvement in care, both inside and outside of the Indian Health Service, both in urban areas and in rural areas. We then have to move along to thinking about access to care, health insurance. Do we have enough doctors to provide care to these communities? Do we have the infrastructure and technology necessary in these communities to provide care? And then finally end with thinking about the quality of the care that's delivered in the hospital setting, in the physician office setting. To give you a sense of the degree of social determinants that we are talking about to address, not only through the delivery system, obviously, but largely through the public health, public policy spectrum. These just show you, I won't read all of these, but the extreme levels of poverty, educational challenges, even lack of basic infrastructure like indoor plumbing or structural issues in the housing, lack of internet access. There are many, many challenges in the Native population. When we think about access to health insurance, the Native population by far is most likely to be uninsured, right, at a rate right here of 21%, higher than any other group in the country. So we in access to health insurance, obviously being fundamental, that limited access to health insurance leads to access to health care problems. Native Americans more likely to report having no doctor, to go without care because of the cost of care, to go without dental care, which is an important predictor of health outcomes as well. Even when they are seen within the Indian Health Service for care, many times those physicians and other clinicians in the Indian Health Service are not able to obtain access for the Native patients when they need access to things like subspecialists, like cardiologists or rheumatologists, or hospital admissions or diagnostic imaging like CAT scans and such. So, because I want to talk a little bit about, spend a few minutes talking about, so what is the delivery system that's set up right now to address these major challenges for the Native population? And I would say that, so we often think about, there's the Federal Indian Health Service, and then there is the rest of the U.S. healthcare delivery system. The Federal Indian Health Service being that system that exists within HHS and the public health system at the federal government level. It is mandated to provide care to Native people who are residing on or who are members of federally recognized tribes and residing on or near their original tribal homelands. That right now is a couple of million people out of the 5 million plus people who identify as Native American. So it's a round sort of ballpark, around 50% of the Native population receives their care through the Indian Health Service right now. That network is about 1,000 federally employed doctors, probably equal to that in terms of tribally employed doctors as well. It's a network of about 50 hospitals and several hundred ambulatory clinics across the country. It is important to know that the Indian Health Service is probably funded right now, again, sort of at about half of the funding that it would otherwise need to care for that population size of a couple of million Native Americans. So it's dramatically underfunded. That obviously leads to deficiencies in being able to hire all the staff that are needed and then be able to have enough clinics and hospitals available to care for that population, and then to pay for things like medications and other treatments. So that stark limitation in access to resources results in challenges in access to care ultimately, and in quality of care and outcomes. There have been recent improvements in the funding stature of the Indian Health Service over the past 20 years, and then in the past few years through some work from the Biden administration, but it remains a dramatically underfunded healthcare system. When you go on the flip side and think about outside of the Indian Health Service, the infrastructure for providing care for the Native American population is through the U.S. healthcare delivery system. And one of the most important things to remember is that the Native American population is probably, as a group, the most reliant on Medicaid funding and the services offered through the Medicaid program. That's in part related to the high levels of poverty in that population. We will, as you see, federal and statewide policies that affect Medicaid policy at the state level, just always recognize those tend to have disproportionate impacts on access to care and quality of care for the Native American population. Both within the Indian Health Service, but increasingly outside of the Indian Health Service. So I know I don't want to sort of go too far over time, but that is sort of a general introduction to sort of health outcomes and quality for Native people and the structure of healthcare delivery for Native people in the country right now.
And hello, everybody. My name is Aila Hoss. I am delighted to be here and greatly appreciate the warm welcome from everyone. I'm joining you from Indianapolis, and the reason that I am here in person has a lot to do with my spouse. There in the middle, Michael. He's a big baseball fan, and it's on his bucket list to go to Fenway Park, which we did last night. I, however, am not a sports ball fan, so if you hear a rumor about some weirdo marking up papers during the Yankees Red Sox game last night, that was me, and I've never been so productive. Got 22 papers marked up. I want to start off by acknowledging as a non-native researcher that I can inadvertently perpetuate the structural violence that I purport to minimize, eradicate in my work. And everything that I know about this work is because an Indigenous person, a tribal practitioner, invited me into their communities and shared their knowledge. And for that, I am immensely grateful. It's been the greatest privilege of my life to do the work that I do. I am a researcher, yes, but first and foremost, I'm a teacher. And so I have an absurd number of slides and materials that I want to share with you all today, knowing that I won't get through all of them, but I'm going to be breezing by. But my very ambitious 20 minutes together is to cover a little bit about tribal governments and federal Indian law, to leverage what was shared by Dr. Sequist and talk about Indian health systems in the context of law and policy, dive into what that means for tribal public health practice, and then to answer the question that is posed in the title for this event, Indian health service, good or bad, helping or harming. And it is absolutely complicated because there's a lot of really wonderful people doing really important work. But at the end of the day, the Indian Health Service is breaching its legal and trust obligations to Indigenous peoples. And I'm going to talk about why that continues to be so difficult to actually address under the law. So I'm going to say tribal and federal Indian law a million times. Okay, how many lawyers in the room? I know we got one, two, a couple, maybe some folks online. Hi, folks online. So it is really easy to conflate tribal law and federal Indian law. When I say tribal law, I'm talking about the laws of individual tribes. So their tribal constitutions, if the tribe has a constitution, their codes, their case law coming out of their judicial branches. It can include their traditional teachings, traditional practices. When I say federal Indian law, I'm literally talking about federal Indian law, a body of law that defines the rights, relationships, and responsibilities between tribes, states, and the federal government. Unfortunately, we cannot talk about tribal sovereignty, tribal governance, without talking about federal Indian law, and that's because of colonization and genocide. Today, the United States recognizes 574 federally recognized tribes within the boundaries of what we now refer to as the United States. Tribes are sovereign nations. They have a nation-to-nation relationship with the federal government, a government-to-government relationship with states and local governments, nation-to-nation relationship with other tribes. The whole process of which tribes are recognized by the federal government is marked by politics, by colonization, by racism. And we don't have a ton of time to talk about it, but essentially modern federal Indian law has either a congressional process or an administrative process in which the federal government can bestow recognition of sovereignty. As sovereigns, tribes maintain jurisdiction over their lands and over their people, Tribal governments pass laws, they have judicial systems, they exercise governance just like any other jurisdiction. And it is patently unfair and inequitable that our education system necessitates the fact that I never have to start a presentation and say, let me tell you what a state is, and this is why it exists, and this is what a local government is, but I always have to provide that preface in the context of tribes. Tribes are part of, quote unquote, the American family of governments. However, because of colonization, as a repercussion of colonization, the federal government has what I call the strings attached. And it has said, yes, we're going to recognize tribal sovereignty, a sovereignty that's existed since time immemorial, but we're going to put conditions on it. And that is where we get into laws of jurisdiction. So jurisdiction is criminal jurisdiction, it's civil jurisdiction. Is that mask mandate the state passed going to apply? Or is the mask mandate the tribe passed going to apply? Who's going to be able to isolate and quarantine? So really complex legal questions. But make no mistake, tribes engage in public health and healthcare and health policy work as part of their governing structures. One of the strings attached is that as part of recognition, as a condition of recognition, federal law says that tribal authority, which is an inherent authority, it's existed since time immemorial, predates the federal government, that their authority is inherent. But if Congress has said that they want to strip away a string of jurisdiction, that they have the authority to do so. And Congress has done that many times. What kinds of things has it done? Environmental protection. Oh, we don't want the tribes to engage in that. Oh, states should have some taxation here. So think about various areas where, as a matter of politics, it would be useful if a state can exercise more jurisdiction. And so that is not the extent of all federal intervention. Sometimes federal intervention exercising their powers has supported tribal sovereignty, but in it, that act itself is very complex. The word that we use that allows, under the law, that allows for Congress to do what they want in the context of stripping away jurisdiction, stripping away authority, is called the plenary power doctrine. The Supreme Court has said that this doctrine is held only by Congress, and plenary means complete, absolute. And this is always the charades I do when I say plenary. Complete, absolute, on any matter related to tribes or Indians. And so, Supreme Court has said that Congress can reduce sovereign powers. Oh no, a tribe can't engage in that particular environmental protection scheme that they might want to do, like regulatory scheme, not like scheming. And it's also allowed for the abrogation of treaty rights. The United States had previously had a long history of treaty making between tribes and the federal government. Treaty making existed even before the federal government was a thing, with colonial governments, even with some states. Constitution says, supremacy clause, the Constitution and the laws made are going to be the supreme law of the land. It also says any treaties made shall be the supreme law of the land. But the Supreme Court has said, actually, congressional plenary power is so mighty that it could abrogate a treaty requirement. And so we also see that in modern and historical applications of the congressional plenary power. What's described as being a product of history, of treaty language, of legislative language, of case law, is this idea that the United States has a trust relationship, trust responsibility to tribes. And much of that has been to protect tribes, tribal jurisdiction, tribes as governments from infringement by states. And so this means trust lands, so tribal reservation lands, for example, are held in trust for the use and benefit of tribes. Federal government is the trustee. It protects the trust assets for the beneficiary, the tribes or individual American Indians, Alaska Natives. Trust assets could be literally money in bank accounts. But the trust relationship, we are told, is more than a financial relationship. It's a moral one, that the United States has the highest responsibility and trust, and to carry out the mandates of federal Indian law, which means honoring and recognizing tribal sovereignty. And yet we know that the US has mismanaged Indian trust for nearly as long as it's been a trustee. So what does this mean for federal Indian healthcare policy? There's really 4 components of the basis of healthcare delivery by the federal government in Indian country. First being military policy. It's actually the foundation of the provision of care in Indian country, because the Indian Affairs was historically originally part of the portfolio for the Department of War. It was called the Indian problem. And so how do you address the Indian problem? Well, you might have some feds engaging in some diplomacy, but there was absolutely a military component of this. And as an effort to protect those serving in the military, there were programs to prevent, let's say, the spread of smallpox to service members, and that might mean providing vaccination or treatment or care. Our modern provision of federal Indian healthcare is based on treaties where the federal government, in exchange for ceded territory, so in exchange for territory that tribes lost, agreed to provide healthcare to many tribes. We've got hundreds of treaties. The language in those treaties varies in terms of, some of them will say, we're going to provide a doctor and a facility for 40 years. And so the treaty language is actually really specific and almost always time-stamped. But that commitment, plus the trust responsibility I told you about, financial and moral responsibility to support tribes, has extended the treaty responsibilities into modern day obligations of the trust obligation and then gone codified in statute. So legislation that gets enacted gets codified. In modern entities, Dr. Sequist tells us that provides for healthcare delivery is the Indian Health Service under the Department of Health and Human Services, but a variety of agencies like the CDC, like the FDA, have a role in supporting public health and healthcare in Indian country. Dr. Sequist told us about what is our three-tier delivery mechanism for healthcare under the federal scheme. One, through agency-operated programs. So, Indian Health Service, a government agency with federal employees or federal contractors in a federally owned building or federally leased building. So, comparison would be Veterans Health Administration. So, government direct provision of healthcare. Because of legislation passed in 1976, the federal government allows tribes to take money that would have been allocated to that tribe or region for healthcare delivery through IHS and allows tribes to have what's called 638 contracts. So the tribe becomes a contractor for the federal government and they decide how they're going to provide that care. That 638 programs have been remarkably successful in terms of giving tribes the flexibility to use the money in the way that they feel is most appropriate, and to be responsible for recruiting and a variety of other clinical and policy decisions in their day-to-day operations. It also has authorized both the IHS and 638 programs. There's going to be contract care, purchase referred care, and pool of money that says, okay, you can't get all the healthcare services that you need at IHS or at a 638 facility. So there's going to be funds available so you can do that via contract from a private provider. So this three-tier system, Indian Health Service Direct Care, tribally contracted care is our T, and then finally urban Indian health programs. So because of a variety of policies, some more gruesome than others, Indian boarding schools, Kill the Indian, Save the Man, displaced thousands of Indigenous children from their homes and communities, and many of whom were murdered and abused in those facilities because of programs like family relocation, among many others. There are a large, and then more modern history of where are the jobs, and often that's going to be in an urban area away from reservation lands. And so a movement of Indigenous people away from either the traditional homeland or they're removed the reservation if there was, whether it's on homeland or if there was removal. So urban Indian health organizations, nonprofits, federally funded through IHS also provide care. ITU, 3 tiers of delivery. I'm not going to talk too much about the structure of IHS. But there are a variety of services they provide, both in terms of direct healthcare and public health. So let's say health education. They do water and sanitation services, actually. So it's a really remarkably broad portfolio. And today, because of the success of 638 programs, we have quite a large number of tribal operated, federally funded facilities. And we're seeing a shrinking of the number of Indian Health Service facilities. These are all federally funded, and I'm going to skip over some of the details about financing and eligibility, but just reiterate what Dr. Sequist already shared, that IHS has always been underfunded. It has always been underfunded. Part of the sovereign responsibilities of any nation is to protect the public health and welfare of their citizens. And so tribes, as part of their inherent authority, has that ability to engage in any type of public health or healthcare programming. Because of the responsibility of the federal government in healthcare delivery, and because in the United States we have so frequently bifurcated healthcare delivery from public health, we have not seen the same, and thank you, I got this. You've not seen the same development of public health programming at tribes as we might see with, let's say, judicial programming or education programming, because everyone thinks, okay, healthcare delivery, that's all we need. That's public healthy enough. And so 574 tribes, the governing structures for public health, there's 574 different ways that's done. Sometimes it's going to look really traditional, quote unquote, to what we expect to see at a state level, that there will be a Department of Health and they'll have a portfolio that you might expect to see. But a lot of times public health activities can be decentralized across multiple tribal agencies. So there might be environmental protection and pollution component, a tribal's healthcare delivery arm through their 638 program might be focusing on screening and vaccination. There could be a social services arm that's going to be focusing on food delivery. And so it's just going to vary from tribe to tribe. And while tribes have the authority, and many do hit all of the components of what we often talk about in the state and local context as the essential public health services, that tribal public health practice might be different. So tribes and the federal government have what we call a concurrent jurisdiction, so that the federal government can have authority in context of public health. They definitely do in the context of health delivery. And tribes are often having to mitigate the failures of federal government by innovating in their own public health and health policies. And so unlike the US Constitution, unlike nearly every state constitution, you have tribes that actually mention health in their constitution. And they have laws, again, like you would expect to see at the federal level or the state level, creating health departments, giving them certain authorities, including regulatory rulemaking authorities. And so every branch of a tribe's government has some authority, whether it's express or not, to engage in public health activities. I want to mention, though, that we do see a lot of similarities in modern tribal governments to the three-branch system that we see at the federal and state level, and that is because of colonization. That is because of federal interference. None of these structures reflect the myriad of traditional means of adjudication and governance across tribal cultures. But the federal government would be like, you want some funding, you should probably have a constitution and you should pass this law. This is a good law, you should pass it. So long history of federal interference. So that is a reality of both. These laws are very important in modern tribal public health laws are very important in modern tribal public health programming and operations. but wouldn't exist in the same way but for the infringement of tribal sovereignty. One of the things that is remarkably beautiful about many tribal laws is that they have a space to incorporate traditional teachings and beliefs. Every state in the US has an involuntary commitment, civil commitment statute. The Navajo Nation talks about the principle, which I'm going to say of K and mispronounce, which means respect, solidarity, compassion, cooperation. Their civil commitment statute talks about dignity, not just due process. And that is something remarkably beautiful and powerful in the incorporation of cultural teachings into modern governance. Beginning of the pandemic, I was really into COVID art. And obviously, Indigenous artists did the best at COVID art. So let's briefly, because I'm about out of time, talk about the breach of trust. Dr. Sequist has already talked about the chronic inadequate funding of Indian Health Service, which funds not just the IHS, but that's where the funding for tribal programs falls too. I've non-native, I've not worked at an Indian Health Service facility, but there are a lot of memes out there about how terrible the care can be. This one's funny, Indigenous humor. Me waiting for my name to be called at IHS. Do you remember this meme going around with Bernie Sanders with the inauguration in 2020? And it's, you have to laugh because what's the alternative when I tell you that there's literally in case law summaries of IHS facilities or IHS funded facilities that didn't have sterile syringes that led to bloodborne disease outbreaks. I could tell you about an Indigenous woman who gave birth on the floor of a bathroom at an IHS hospital. I could tell you a million other stories. That's not to say every facility provides that substandard of care, that there are good people trying to do good work, but there's also, as some investigations have shown, folks that shouldn't have jobs providing care at these facilities. A big shift in federal policy related to the federal government's trust responsibility and funding in Indian country came out of a 1928 federally commissioned report called the Merriam Report. I could pluck a million different quotes where they talk about malnutrition at boarding schools. Even though treaty responsibility to provide healthcare, people going in to see the physician for treatable conditions and then living with them for years until they get worse. And the reason why this persists, the reason why this report from 1928 and then many reports from the Commission of Civil Rights since have said the same thing. They say it in different ways. Federal government has reneged in its promises, its legal obligations in healthcare delivery, that Indian Health Service is inadequately funded, that the system is inequitable. And despite that, despite hundreds of years of evidence of that, the law does not offer protection to anyone except for the federal government. So we have Supreme Court precedents, for example, Lincoln v. Vigil, that said, oh yeah, IHS closed this really important program to the community serving Indigenous children with disabilities, but discretion, agency discretion, they're allowed to do that. We could talk about Rosebud Sioux case, ended up going to federal circuit court, where CMS was like, there are so many violations, we're literally closing down this hospital, and they did. And even though eventually the circuit court said, yeah, you know, the federal government has breached its trust by providing terrible care at this facility, by closing down this hospital, and meaning the closest emergency facilities was going to be over 50 miles away for most of the folks in the service area. And this language is beautiful and meaningful. But you know what the rest of the case says? The only thing we have jurisdiction to do is declare, it's called declaratory relief. The federal government broke the law and they breached its trust obligation. No monetary damages. Breach of trust doesn't allow that. And since the hospital, by the time that this case went up at the circuit court in 2021, had reopened, there's no injunctive relief forcing something to happen. That's it. And so this statement was so hard won. Rosebud Sioux Tribe engaged in this litigation, knowing that the relief was going to be the federal government, you broke the law. With that, I'm going to stop there and pass the baton over to Dr. Pham for our Q&A. Looking forward to hearing your questions and comments. Thanks, folks.
Testing. Thank you so much for those presentations. I did want to ask a few questions, particularly about the intersection between the need for cultural and political sovereignty in tribal nations, but also what was alluded to as a history of structural racism, colonization, and other legal acts of oppression. And these disparities in health outcomes and healthcare delivery among American Indian and Alaska Native communities. Could we hear more about the almost mechanistic relationships between these, again, these periods of colonization and oppression and these disparities in healthcare delivery and outcomes?
I'm happy to kick us off, and then Dr. Sequist might have some other thoughts. I got my own. What I didn't say clearly enough, but I will say now, it is on purpose that the federal Indian healthcare delivery system looks the way it does. It is on purpose that it is so much more convenient and cheaper for the federal government not to provide the quality of care that Indigenous communities and tribes are entitled to. This is about politics, because who's gonna force this? We have 26 states with federally recognized tribes within their borders. So there is times a view that you can get your federal delegation to lobby Congress, and that has absolutely happened. But what about all the other states that still have Indigenous populations, may have tribes without federal recognition, and not to mention the myriad of ways that their own citizens and the government benefit from the forced removal of tribes in that area? Well, it's not politically very compelling for a lot of folks. The racism that permeates the quality of care, the access of care, the chronic underfunding, the loophole. I hate using the word loopholes because they're there by design. It's not like it's magic. Either someone didn't think about it or put it there on purpose. But the loopholes that lead always and forever for Indigenous people to have worse quality of care. Racism has so much to do with that. And so I shared stories about healthcare delivery funded by IHS, but I could tell you about public and private providers. Lovelace Hospital in Albuquerque, New Mexico, after the birth of Indigenous children, the mothers were taken from them immediately on the pretext of COVID. This is early 2020. even though there was no evidence that that birthing parent had COVID, or that they were coming from a tribe or even living on a reservation with COVID cases. Plenty of peer-reviewed studies about differences in the quality of care, even with folks that think they're providing the same level of care. That's all I got right now.
That's a good answer. I'd also like to hand the baton proverbially, Dr. Sequist. Do you have any other comments on that topic that you wanted to mention? Oh no, microphone.
Jeez,
Classic Zoom.
been 4 years, sorry. I guess I could take a, like I'll put a little bit of a clinical spin on this. So it is 100% true. It's really important, and I guess that's why I'm going to say it again. It's worth restating that the policy positions of the federal and state governments over the past, 250 years have resulted in extreme adverse health outcomes for Native populations. I mean, I showed you the slide, right? That the average life expectancy is 65 years. It's really important for that to sink in, that number is what, 10 years shorter, right? Than people living at than other race ethnic groups living at the higher end of the life expectancy spectrum. Those policies that have resulted in that, it's really important not to understate that they are not that there are not unintended consequences of those policies. They were fully intended consequences of those policies. They weren't, the people putting this in place weren't being absent-minded or sort of careless. So it just, we continue to make decisions that in the clinical space make it very hard to deliver the care that's needed. It's one thing to, and so I'll just make this sort of even more sort of poignant. So it's one thing to say like the funding is $4 billion short. The issue with that is sort of like when you hear that at the national federal level, none of us know what $4 billion. Well, I don't know who's in the room. Maybe there's some people in there who know what $4 billion looks like, but I don't know what $4 billion look like. And we have no idea the implications of what that means, right? But like when you get to the ground level in these hospitals where 30% of the physician slots are vacant, meaning there's just no doctor there, right? And that 60% of the doctors in these clinics say that they are providing care that's outside of their comfort zone for providing care because there's no other resources to provide the care. The thing about that, right? If you went to see your physician and you had a complaint, how would you feel if in the back of you knew that in the back of your physician's mind, they were sort of like, I don't really entirely know how to treat this thing, but I'm going to go forth because there's no one else to treat it. That's the kind of scenario that gets created, right? During the COVID pandemic, what did we all learn to rely on, right? Zoom, in the healthcare space, right? Virtual visits, virtual care. So what do you need to conduct a virtual visit? Like, how am I on the Zoom right now? Broadband internet connections, right? Like high capacity internet connections. Those are non-existent in many, if not most, tribal communities. What that means is that we lost a lifeline to care, right? In terms of video conferencing. It also means, by the way, remember, the national push to have an electronic health record system, right? Which we believe is a way to improve quality, like computerizing, modernizing our health systems. Well, those electronic health records need an internet connection to work well. And in many of these spaces where they don't have reliable access, they don't have the EHR, the electronic record, can just go down, for days at a time. These things are catastrophic for healthcare. Now, why do I say that that's how is that like a direct effect of policy? Well, there's a very specific decisions that are made around whether we lay broadband cable to these communities, right? And we have just decided not to. And the list goes on and on. Grocery stores, healthy grocery stores, We have decided not to have those there. Somehow the fast food companies figure out how to get the food to these communities, but not the grocery stores, right? And it is just, it like the list goes on in terms of the impacts to the health of these communities.
Thank you. I wanted to raise the issue of mental health, probably because I'm biased as a psychiatrist, but also I think it's an important issue. You know, in my clinical practice, I feel like I'm often doing live translation of evidence-based care for people who may not see the evidence-based care as best practice for them. I've also been humbled to have worked under Dr. Joseph Gahn as his postdoctoral fellow, where I learned a lot about how historical trauma and structural racism played into health disparities, specifically mental health disparities. As you mentioned, suicide rates are much higher in American Indian and Alaskan Native populations. Could I hear more about how cultural subjugation and oppression have perhaps played a role in these mental health care disparities?
Dr. Sequist, do you want to kick this one off? I can supplement if needed.
Yeah, I mean, so that is a question outside the delivery system, right? So that those efforts actually aren't part of like the creation of the Indian Health Service. Those efforts, those things go back 500 years, right? And you know, I think of it as like so this very well sort of formulated ideas and data around the well-being of the community being linked to the well-being of the individuals. And what we have seen is a sort of tearing down not only of the community infrastructure in these spaces, but then the culture of these spaces. And again, I'm going to keep hounding on that wasn't by accident. That was very specifically, right, like federal policy around removal of these cultures in any way, shape, or form. Many people of my parents' age were taken away to boarding schools with the explicit goal of don't speak your native language there, and removing you from your culture. That obviously has led to and was the goal, the sort of destruction of the fabric of these communities. What we're seeing then, as you think about resiliency of these communities, and sort of it's a challenging word, resiliency, but like what you're seeing within the response to these communities is this sort of spiral, right, that revolves around, I think, racism that leads to poverty, poverty that then explodes into a number of conditions, including chronic disease and mental illness. On the mental health space, in the mental illness space, we're not seeing just the suicide rates that you were referring to before, but the broad spread sort of depression, and increasingly right now substance use disorder as one of the leading causes of rapid growth in mortality rates among American Indians. All of these things are all linked, and I not to be a broken record, is all links back to racism, right? Like this all links back to what our intentionality was in dealing with these communities over time.
Thank you, Dr. Sequist. I'm not a clinician, not speaking from lived experience. My knowledge base here is purely from what I have learned or has been shared with me. But there's a robust body of traditional peer-reviewed scientific evidence, but also anecdotal community stories, oral history of the generational impact of the violence and trauma of boarding schools, of the criminalization of engaging in religious practices, in the destruction and pollution and mining of sacred sites essential to the provision or the practice of certain sacred ceremonies, the forced removal from homelands, the decades-long litigation for desperately trying to hold federal government accountable, even though the law's not going to end up being on tribe's side most of the time. That has an impact, and it manifests in people's bodies, in their communities, and by design, Dr. Sequist says, these policies, sometimes I'll tell my students, I didn't talk about it, but one of the brilliant policies coming out of the federal government was allotment or checkerboarding. So taking reservation trust lands, slicing them up to pieces and giving them to the tribal families, yes, but whatever surplus land was there, giving them out to non-native families as a move for assimilation. And so as a matter of law in my federal Indian law class, I'll tell my students, I was like, these folks were nuts. What do you do about jurisdiction then? You've got non-native people living on the reservation within the jurisdiction of the tribe, but they own the land in fee simple. They're not, who has jurisdiction? What were they thinking? And the truth of the answer is it was done on purpose because the goal had been tribes aren't going to survive this, whether it's termination, assimilation, in earlier periods, military activities, eradication of entire tribes from health conditions. That was the point. And so even if you look at modern policies today, Dr. Sequist showed a beautiful photo from his home, Task Pueblo. And you see, and I'm not, Dr. Sequist can talk more about the structure of families and living arrangements, but you see these buildings close together, large spaces that are going to have whole communities living there. You know how HUD, Housing and Urban Development funding goes? It's not to build traditional development, it's to build single family homes. If you want the funding, then this is the homes you're going to have to build. And so you can see a myriad of ways, not just in history, but in modern day, where cultural traditions are being undercut. And it's easy to say today, well, it's not by design. Those folks at HUD just don't know anything, but shouldn't they? They have a mandatory legal treaty, trust, and statutory obligations.
Thank you. On this subject, then I'd like to transition to the topic of solutions. This might be more of a question for you, Professor Hoss, but could we learn more about how law and culture could play a role in supporting tribal public health and to promote and protect culture?
Absolutely, and I'm so glad she asked because when I don't have a ton of time to talk about what I've learned in the work that I do, it's really easy for me to want to center federal government's abuses and reneging of legal responsibilities, and whether you call it resiliency or tribal strengths, would be patently unfair if I characterized whole hog tribal governments and tribal communities as fully impoverished, not having the mechanisms to govern, because that's not the case. And also that kind of stereotyping, you could say the federal and state and local level too. Which government does a great job at everything? None of them. Tribal COVID-19 response was swift. It was powerful. It was community driven. Tribal leaders, tribal employees, volunteers that knew their communities and that they could respond so quickly because the governing structure and the leadership structure allowed for swift decision-making. Tribal vaccination programs, the most effective in the country. And when they had surplus, they made sure that their employees other folks living on the reservation and the broader community had access to those vaccines. Swinomish tribe has innovated in so many ways. They've literally from scratch, independent of federal funding, created a whole new type of provider for dental health aid, created the educational program for it, graduated their citizens from the program, and filled the gap for dental services, which is now recognized both in Washington and can get federal support, and is a model for other tribes. Alaska, healthcare delivery in Alaska is just hard, period. But the only multi-organization, multi-tribal compact under Indian Health Service 638 program has been in Alaska. And so the kind of hub and spoke model of these are the facilities that have internet access, and maybe we can't get in-person care, but we could get someone 20 miles away via the puddle jumper airplane to this facility with the internet, and then they could speak to a specialist. I mean, they have been innovating in that regard in terms of rural healthcare, particularly in non-drivable areas, for decades. And so much of that is community driven and cultural driven. And I can't speak to any one tribe's culture, but again, both the scientific traditional evidence and the experiences of Indigenous public health practitioners on the ground have shown that building community and culture leads to better outcomes as a matter of policy and as a matter of health outcomes. And some tribes have been leaders, not just in Indian country and not just for their communities. You look at the Lummi Nation in Carolinas, they don't get a lot of snow, but when they do, they don't have the snow plows, right? And that's dangerous and has health consequences. And you know who's got the snow plows? The Lummi Nation. You know who agrees to support the broader communities in the other counties, the Lumbee Nation. And so you see that kind of generosity and community in a lot of tribes when they've got the capacity. And I think speaking to that is really important, tribal strengths, because it's that Navajo Nation Health Commitment Act, no state law talks about dignity. It's just, it doesn't. It talks about due process. It doesn't talk about dignity. And how meaningful and impactful I think that is.
Thank you. Dr. Sequist, did you have any other thoughts on that?
No, that was great.
It is nice to have a lawyer on board. You know, we also talked about technology, medical record systems, lack of access to broadband internet, the necessity for Zoom healthcare in the context of post-pandemic times. Could we hear more about opportunities and challenges for health technology within American Indian and Alaskan Native communities?
You want to narrow it a little bit? Like, do you have a specific kind of thing that you're focused on?
Yeah, maybe just potential innovations within the medical record system or teleconferencing technology that could improve health outcomes.
I mean, I think across the country, right, video technology, telemedicine technology has a great potential to improve access to care primarily. And, you know, we're learning about its impact on health outcomes and how it can improve health outcomes. I think the COVID pandemic advanced us maybe like 30 years in one leap, like over about a month. Mainly, importantly, with our lawyer, our member of the panel is a lawyer, mainly because all the regulations were removed, like in the time of the emergency, and they just let technology work. Now, that obviously regulations are there to help with some things, right? But some of the regulatory stuff was just old and in the way of, like, you know, this classic joke, right? We still use fax machines in our hospitals. It's not a joke, it's actually real, because that's what's allowed for us to use. So I would say that to me, the some of the challenges that technology can help with in tribal areas is kind of routine types of follow-up and care and monitoring that are very hard to do right now because the distances are so large, because there is not, again, I'm going to go back to infrastructure, there's not routine cell coverage, and there's not actually routine electricity. And so if you don't have those two things, and I'm sorry, and the roads are often not in great shape. And so if you don't have that collection of things, it becomes very hard to do what I would term like routine follow-up. So what do I mean by that? Let's say you have an injury or an infection, and you see the doctor and they need to look at it again in a couple of days to make sure it's still going okay. So there's two ways to look at it, right? They come back in, but what if that is like a 3-hour journey for you to come back in, or video technology, right? So there's vast potential, I think, to improve access. That's why I was calling it access to care, right, for these populations. But I think that the challenge is for us to be able to do that, like in terms of like what enhancements we would need, to your question of like what enhancements we would need, I think we need a couple. But so we need pure infrastructure enhancements. And by that, I really do, I so strongly believe that broadband technology should be available 100% everywhere in the country, right? Like that should not be something that's considered to be a privilege in 2023. Once we have that, when we're working with tribal communities, I think the next thing we need is on the recipient side, the patient side, we need to be able to enable them with a few things. They need the hardware access, right? It's not like there's an abundance of iPads or other kinds of tablets or laptop computers and such. And so they need to A, have the hardware. They need to B, be able to understand how to use the software, right? Which is a challenge probably for all of us here and there, right? In terms of many of these apps and such. And so we need, and what that requires is training, like, right? Like on-hand support to be able to help these patients understand how to use the tools that we are giving them. And so once we have that, right, the big infrastructure like the broadband, and then they have the hardware, and then we provide the training to use the software, like then we can start to make some advances. And then the last thing I would say is all of these IS tool or digital tools, let's say, they're not developed through the lens of the users other than the generic US user. And that lens tends to be upper middle class and wealthy Americans, a majority of whom are white. And those tend to be who that many of those tools are targeted towards in terms of usability and such. And so we find here in Boston, and I think you find all around the country, that when you then try to use, have those apps be used by other populations, those healthcare apps, they can't be used. It's sort of like the easiest way to understand that is like, I could build an app from the ground up and take 2 years to design it and build it. And then it's working well. And then I say, I want to use this now in the Spanish speaking population. Well, let's just translate the thing as is into Spanish. And that like never works, right? Because it wasn't designed from the ground up for a Spanish speaking population. It's like watching a movie, right? That's been dubbed over in the language that you want to watch it in. It looks kind of silly. When we think about tribal healthcare as well, right? We need to think about it through that lens. When we design this tool from the ground up, how do we design the tool from the ground up? Whether it's an app on your smartphone, or whether it's a program, a full program on a computer, or the design of the electronic health record in and of itself, we need to be able to design those from the ground up so they meet the needs of these communities. I'll give you like one last example. So on the electronic health record, right now there are increasing mandates coming from CMS around collection of what they've labeled social risk factors, right? So not just race and ethnicity, these sort of real things, like, race, ethnicity, language, but then also we've started to add in social risk factors, right? Food and housing insecurity. But what you need to collect in many tribal areas is like, do you have electricity? Do you have indoor plumbing, right? Do you have a road that goes to your house? I probably wouldn't ask those questions to the broad population in Boston. So that the EHR works well in Boston for that, right? But would it work well in many tribal communities if you're trying to get to the biggest social risk factors, the biggest things that are creating impediments to health? And right now, as most EHRs exist, they wouldn't collect many of those things that are really important in tribal communities. So that sort of partnership with the community that's going to be using the tools is important. But you need a real commitment to do that, because if you're the EHR company or the technology company, where's your what's your motivation to do that? Let's say you're a for-profit company. What's your motivation to do that? So how do we create the incentives, right, for those kinds of industries to be able to partner at that level?
I wanted to add just one thing. Most of my research and the small slice of practice that I continue to do has been related to public health data surveillance since the start of the pandemic. And so the ITU system is the primary provider of healthcare in Indian country. State public health surveillance is done at the state level. Those are state requirements for reporting. Unless a state requires that by statute, unless their legislature requires that the state health department provide that information to the CDC, it's done voluntarily. So that is already creates so many gaps and disconnects. But now you got IHS, which is a federal facility, and the federal laws and policies related to collection of data it's nutty and unbelievable. A lot of it is more administrative in terms of what equipment do you have, and so there's that component, and we already know IHS is underfunded, and they don't have the medical equipment they need, let alone the EHR systems. And then tribes, as part of their 638, are getting to do what they want with their programs. And so every tribal delivery system is going to have a different system. And so that really, on the one hand, supports tribal self-governance and sovereignty and independence, but on the other hand, makes it literally impossible to have comprehensive data coming out of the 638 facilities. It is really easy to look at that problem and say, that's bad, we need better data, but this is also implicating tribal sovereignty and the ability to keep their data in-house. That if it goes through the state system, which it will end up going through the system, the tribe ends up having no control of how that data is used, how it's presented, if it's actually going to be useful to tribes. And chances are, in many states wouldn't even give tribes access to that data, even though they're legally authorized to have it under federal law. So yes, I want there to be better EHR systems, because we don't have effective surveillance, and without numbers, it's really hard to ask Congress for things, and it's really hard to compete for grants. But at the same time, it is again forcing tribes to adopt this one standard and threshold in order to get more support that they're legally entitled to. So it's complicated.
Yeah, it does sound complicated, and yet there seems to be a need for rapid solutions from what I hear. I know time is coming up, but I heard there's a question in the chat.
Thank you. So there are two questions from people who've joined us online that are similar about, we've said that IHS is underfunded and there's this need for more funding there, but what about other services like Medicaid that is many tribal members are already enrolled in, and so expanding provision through some of these other programs?
So folks should understand, the funding, we didn't talk about this, but the funding of healthcare for American Indians is quite different than any other group. And I always say, you may hear people say different for any other race or ethnic group. It's because American Indians aren't a race group. In this scenario, they are nations negotiating with the federal government. It's really important, right? It's not that the government picked a race and then decided that race we will create a different funding mechanism. It's a nation to nation sort of treaty, right? So anyway, how it gets funded, if you are American Indian, so first, a lot of this is contingent on being labeled a member of a federally recognized tribe. And boy, we could go on and on about what that means, and that's frustrating. And when has it ever worked out well for a member of a government's population that they are labeling you, and I have a card that labels me as American Indian. That's never worked out well for any population where a government was creating that kind of a program. But I'll put that, that's a whole other topic. I'll put that aside for a second. If you are a member of a federally recognized tribe and you are then eligible to receive healthcare through the Indian Health Service, and let's say you arrive at the Indian Health Service, they would consider the Indian Health Service to be a payer of last resort, right? So they would first look, are you employed and do you have commercial health insurance? If not, do you qualify for the Medicare program, which is people over 65 and people under 65 with certain health conditions? If not, do you qualify for the Medicaid program, which is children and people living under a certain income threshold? And if not, then Indian Health Service. So they're actually, that was a long preamble to saying they're not actually independent of each other, the Indian Health Service and Medicare and Medicaid programs. That's actually different than like the VA. Which has a different structure. There's a difference between the entitlement programs and the trust programs that were discussed earlier. So from a funding, if we just say from a funding standpoint, is there an opportunity for the federal government to help improve healthcare? I would say yes, expand Medicaid funding, because that is vital to access to care for the Native population, and expand Indian Health Service funding. So two separate streams. If you're asking on the delivery side, is there an opportunity for the federal government? Well, the federal government doesn't actually run many hospitals in the country, right? They don't run any of the 4,500 to 5,000, private hospitals. They just provide funding through the Medicare program. They do run the Indian Health Service hospitals. The challenge to, like, one of the things that often comes up when we talk about this is, well, why don't you just create like an insurance card that's like, Indian healthcare insurance, and the eligible Native population, meaning those people who are members of federally recognized tribes, could take that insurance card to like here in Boston or anywhere. There's a geography problem, right? Like the largest clustering of these populations are not near so much of the private healthcare infrastructure. So just like getting rid of the Indian Health Service as a structure, as a hospital infrastructure, and just saying here's an insurance card would not really be a viable solution to ensuring good access to care and quality care for the population. So just think of it in two veins, right? One is funding, and then the other is actual hospitals and infrastructure.
I would add that, remember, Medicaid is co-administered, co-funded by the states and the federal government, and states have significant amount of flexibility. And so even when the federal government or Congress through the ACA tried to mandate Medicaid expansion, the Supreme Court struck that down. So all the problems with Medicaid as it is, the disparities you've seen between the states that have expanded and those that haven't, the number of providers willing to accept Medicaid is going to create extra burdens on people of color, and including Indigenous people. So yeah, Medicaid expansion has been so important. The marketplace has been so important in Indian country and to tribes, because having a third party payer means more income. But that there has to be the mechanisms to have that. My smartphone's broken, it keeps meddling.
Technology. Lastly, anyone in the audience, any questions that may have come up? Technology is great.
Can you hear me? Yes. My name is Konstantin. I'm an alumnus of the MB program, a doctoral student in bioethics at Loyola University Chicago. Very quick question, based on what you were just saying, and I remember from your presentation that we had a lot of data about the shrinking of the federally funded facilities versus the expansion, Dr. Moss, the expansion of the local ones. So given what we're just hearing, is that something that is that something good, something that should be expanded? So the shrinking on one part versus the based on a cost efficiency ratio, which I know some people are criticizing that also, but is that a good trend or not? Thank you.
I'm curious, Dr. Sequist has thoughts. This is something that continues to be active point of conversation in all of the Indian healthcare and tribal public health circuits and conferences. There's not a ton of evidence in terms of peer-reviewed scientific studies on the impact of 638 facilities. And part of that is because each tribe is going to pick which services, so they don't have to do all of them. They can say, we're just going to do behavioral health, or we're going to just do diabetes. And then because of tribal sovereignty, they have a right not to share that data and not have it studied. And given the long history of academic and research misuse, it's probably really prudent of them. There is unfortunately, I'm going to go ahead and say it, really terrible dissertation that came out a few months ago that tried to, from an economic analysis, suggests that 638 programs were worse for Indian country because mortality rates were higher for the counties. They have to do it by county as a proxy for tribe, were higher in those counties. And it really was completely absent of any of the cultural and historical and political landscape that could also account for those differences. It was very obvious someone that is not Indigenous and has no experience in Indian country, and that they didn't consult with tribes before producing and publishing that research. So I don't think the data's gonna be there, although I'm sure IHS has a lot, but in my experience from one Indian country, that these programs have been remarkably successful, have given a lot more flexibility. There are some tribes that are just never going to 638. And I think very few tribes in the next few decades that are going to want to 638 everything. So there's always going to be a role for IHS, but I think it allows for a lot of creativity and innovations that IHS and governments, with no surprise, aren't really very equipped to be that nimble. I don't know, do you have any thoughts on this, Dr. Sequist?
I think one of the things I agree with everything you said, but one thing to reemphasize, we don't know. Like large scale over the past 20 years, let's say, as the tribal funding has really increased, 25 years, let's say, we don't actually know the impact of that on health outcomes. I would say the reality, right, is that a lot of this, the shifting of funds is, because there has historically been poor health outcomes. These are tribes exerting sovereignty and trying to do the best for their communities. And, there is baked in just a lot of well-earned mistrust. There is also, it can be pretty inflexible to be federally funded, right? You can't go after federal grants because you are the federal government. Like if you're a federally funded clinic, right? You can't do advocacy because who are you advocating to? Yourself, because you're the federal government. So there's a lot of the kind of the flexibility that you were referring to. Yeah, like on the ground, a lot of the ways like federally qualified or sort of community health centers across the country, like they run separate programs because they can apply for grants. They can apply for X, Y, and Z. You just can't, you don't have that flexibility if you are a federally run facility. Now, I'll just give you the other side of the coin. In the science of like healthcare and delivery systems, integration and coordination is the direction that many systems are going, right? To standardize care, because healthcare as an industry is 50 years behind other industries that have standardized and optimized and over time, improved, their functioning as a service industry. I'm talking not healthcare, but any other kind of industry. So healthcare is trying to catch up with that. So the model of like unintegrating and becoming smaller parts is probably not in line with many other industries. But I just emphasize we don't know the answer here, and I will just emphasize like the standardized sort of federal IHS process seems not to have worked, right? Like now, the key question is like why didn't it work, right? And that's what we've been talking about this whole time. I'm not convinced that it's because the model of standardizing care doesn't work. I think that model works. That there are just other issues at play.
Thank you so much. We are over time. Appreciate everything.